Thank you for the kind introduction. Today, I will present our study titled Renal Recovery Benefit of Living Donor Compared to Deceased Donor Liver Transplantation in High-MELD score recipient. I have no CI. High-MELD patients are characterized for DDAT in Korea. However, due to limited number of organs, among patients with a MELD score above 35 who do not have a living donor, waiting list mortality exceeds 50%. LDAT is an alternative option, offering timely surgery, good graft quality, and shorter ischemic time. High-MELD patients usually present with multi-organ dysfunction, such as mechanical ventilation, renal replacement therapy, and vasopressor support. These conditions increase perioperative risk, thus an ethical dilemma arises because LDAT is technically more difficult than DDAT, and also involves surgical risk for a healthy donor. For this reason, in 2002, LDAT was not recommended for candidates with high MELD score and all requiring RRT. However, recent data from high volume centers suggest improved outcomes. Then, are there additional benefits of LDAT compared to DDAT in this high-risk recipient? In 2021, a group from Hong Kong reported a study focusing on patients with MELD score above 25 and HRS. They found that LDAT achieved comparable outcomes and offered a better chance of renal recovery. Our center also published a study in age 18 on LDAT in patients with HRS. In the study, patients who achieved renal recovery from HRS had a better survival, and the time interval from HRS to LDAT was identified as a significant factor for renal recovery. To date, studies focusing on MELD score above 35 are extremely limited. Therefore, this study aims to compare perioperative outcomes, particularly renal recovery, between LDAT and DDAT in patients with MELD score above 35, and to identify factors associated with post-transplant prognosis. We performed a retrospective study of liver transplant at Asan Medical Center between January 2000 and June 2021. Only patients with MELD score above 35 were included. Among over 7,080 cases, 712 patients were included. Propensity score matching was performed at a 1-to-1 ratio to minimize selection biases, resulting in 188 matched pairs. This slide shows our center's algorithm for AT in high MELD score patients. All patients were registered on the DDAT waiting list, and for those with available living donor, LDAT was considered as an alternative. Patients requiring ECMO, ongoing high-dose vasopressor, or recent severe infection were considered as high-risk candidate. We preferred donor with an estimated GRWR over 1 point, anatomically simple case, and age under 35. Maintenance immunosuppression was based on tacrolimus in patients with impaired renal function. To minimize CNI exposure, we prescribed MMF. Renal recovery was defined as discontinuation of RRT in patients who require preoperative RRT. Cox regression analysis were performed to identify independent risk factors for overall survival. When comparing LDAT and DDAT recipient before PSM, several differences were observed. Portal hypertension symptoms were generally more prevalent in DDAT group. ICU stay before transplantation was similar, but preoperative RRT was significantly more frequent in DDAT recipient. After matching, no significant differences remained in baseline characteristics. This table shows significant differences in graft characteristics between groups. Median graft weight and GRWR was lower in the LDAT group. Ischemic time was markedly shorter in the LDAT group, but operation time was slightly longer. Despite these differences, ICU stay and post-operative hospital stay were not significantly different. Surgical complications were more common in LDAT. This because maybe due to biliary complications. However, in-hospital mortality was significantly lower in the LDAT group. As shown in this Kaplan-Meier curve, The ADAT group demonstrates significantly superior overall and graft survival compared to the DDAT group. To evaluate renal benefit, we performed the subgroup analysis of patients requiring preoperative RRT. After PSM, 73 matched pairs were analyzed with well-balanced characteristics. Surgical outcomes and complications in this subgroup were also similar to those in the total cohort. Importantly, renal recovery was significantly higher in the ADAT group. This likely reflects the advantage of timely transplantation, allowing earlier hepatic recovery and reversal of hepatorenal physiology. Renal recovery plays a crucial role in post-transplant outcome. In fact, patients weaned off the dialysis had a significantly better long-term survival than those who remained dialysis dependent. In risk factor analysis, age over 65, retransplantation, and vasopressor use remained independent risk factors for overall survival. ADAT was not significantly risk factors for overall survival in High-MELD score patients following this study. This study has limitations. Renal recovery was defined based on discontinuation of RRT. Objective measures such as GFR and serum creatinine level were not consistently available for patients not requiring RRT. In conclusion, this study suggests that in selected high-risk patients with MELD score above 35, timely ADAT may offer a survival advantage. Notably, in patients requiring preoperative RRT, ADAT was associated with significant improved renal recovery. ADAT can be a safe option that maximizes recipient outcomes while preserving donor safety and selecting high-MELD recipient. Thank you for attention.